My name is Paulina Kloskowska, and I'm a physiotherapist, and I'm also a researcher. Thank you very much for inviting me in this beautiful city. Raf couldn't be here, and therefore I decided to take a liberty and slightly change the focus of this speech. So this was supposed to be a clinical excellence in running. What I decided to do is I decided to take a little bit more biomechanical angle, since this conference subtitle is Clinical Reasoning and Practice. I thought I'm going to hit this clinical reasoning and running a little bit more. So if you just stay with me through the biomechanical bits, which I promise will make sense at the end, then I'll be very grateful. So first of all, thanks a lot, Christian, for your excellent presentation, which I do believe is a very important step for us all clinicians and gives us so many very useful tools to manage this difficult problem. My approach would be more biomechanical, and for purpose I've put this very scary picture here about vectors, forces, angles and torques. But please do stay with me because I'm going to make it all clinically applicable. My questions throughout here is, do we think as clinicians, do we need to understand the biomechanics of the area? Do you think it's necessary? Is it useful in clinical practice? How clinically applicable it is? Well, I'm going to try to convince you it is very important, especially in an area such as groin, where we have so many different forces, torques, and so many different directions that act on these little joints such as pubic symphysis or massive joints such as hip joint that have to work together in balance in order to work optimally. Right, so first of all, let's look at the pubic symphysis joint. There is a number of functional ligaments that are stabilizing the joint from the front, which provide the strap for anterior pelvis and hip. And this is great, but unfortunately this is another area for stress. There is a lot of muscular attachments around the pubic symphysis in the joint. However, because we're talking about groin today, we're going to focus on three main muscles. First of all, abdominals, which I personally think are underrated in groin pain. Secondly, we're going to talk about medial compartment, mainly adductor longus muscle with this massive tendon, which is attaching just inferiorly and laterally to the pubic symphysis, and the anterior compartment, which is mainly quadriceps muscle and iliopsoas, or psoas major if we want to be purists. And this is just a cadaveric picture of the area. It just shows you how many tissues we have there, how many tissues and how many structures are attaching to the groin pubic symphysis area. You can see this massive adductor longus tendon here, which is obviously able to perform such massive loads. Right, so when we look from more of a force production perspective, this is a lateral view of the hip. We can see the acetabulum here. Don't get scared about this picture. We are only going to focus on two muscles here. The one arrow up is a rectus abdominis muscle. Arrow 2 is a adductor longus muscle. As you can see from a lateral view, these two muscles produce actually opposite torques and opposite forces. From medial view, we can see that these forces are also opposite, and they obviously work on the pubic symphysis. This is just another picture, an oblique view to show you how they are oriented against each other. So that's the pelvis. So that's the pubic symphysis and how many loads this little joint has to cope with. Now let's have a look at the hip joint. So in my opinion, hip joint is where the stability and the mobility meets. This is where we have this massive stable mechanism, such as negative pressure, a lot of ligaments, but also we have to remember that this is a ball and socket joint with 6 degrees of freedom. We have over 20 muscles working on the joint, and this joint has a main function in all the lower limb movements as a main power generator. So I'm just going to talk about hip joint reaction force, which is the main force acting at the hip joint, and we're going to consider standing on both legs only right now. Obviously, one major force acting on the joint is a body weight. And for that, we need to add the hip abductor muscle force. And these two forces, while acting on a hip joint in order to maintain stability, create the hip joint reaction force which compresses the joint and is problematic. Now, if we think about standing on both legs, this is the situation. If we think about standing on one leg, this is where it all gets complex. This is where all of these balances needs to be working perfectly. And if we think about sport-specific movement, this is getting even worse. And if we think about running as not even a off-balance, on-balance movement, but a series of single leg stances with increased speed, this is where we understand how demanding running is for the area. Right, so what are the athletic implications of this basic biomechanics of these two joints? So first of all, we have increased torques in both pubic symphysis and joints. These are athletes. These guys are strong and well-trained. So from the perspective of pubic symphysis, which is a fulcrum for all of these torques working around, and major muscles create increased force which may oppose each other, such as adductor longus and abdominals. From the hip perspective, there's an increased range of movement very often. Think about kicking, think about long striding and running with a very powerful muscle output. And obviously the balance of these muscles is difficult taking into account sport-specific movements. So we can see that all of these forces produced by all of these muscles can lead to injuries if there are any imbalances, if there's any weakness, if there is any dysfunction or decreased activation or timing of these muscles. Right, so the next step I was thinking, okay, so we have all this nice biomechanical theory. Can we see this in the research? Is there anything in the research that shows that this is the case? So first of all, there is a number of nice systematic reviews which I strongly recommend. And they all try to differentiate the athletes with groin pain with athletes without. These are all very clinically relevant. If you're working especially in the teams, you can screen your athletes, you can see what's happening with the athletes, and then make a decision whether there's an increased risk of injury or not. I'm going to talk about some of these risk factors and associations, but I'm going to focus on my own review that I done last year, because we were in particularly focusing on the biomechanical factors rather than other not related. So first of all, what are the risk factors? Are there any evidence for biomechanical risk factors for athletes in groin pain? Well, there are some non-specific to groin pain, which I just wanted to mention because they seem quite interesting and also quite relevant looking at the presentation that Karim Khan gave this morning. So there is a decreased preseason sport-specific training that is one of the risk factors for the injury, which is very much in line with what was talked about today about training load. In terms of biomechanical specific risk factors, there is one massive risk factor that we can see. The athletes, before they get groin pain, they are weaker in their adductors. And this is very important information, and it's quite consistent in 3 different modes, I would say. So first of all, when you have a team and you screen the preseason athletes, they are already weaker preseason, the ones who later are over a higher risk of groin injury. There was also the second nice study saying that 2 weeks prior to injury, there's an immediate decrease of adductor strength, which is quite interesting and may suggest some neurological mechanism. The other thing is the balance, so the relative weakness of adductor muscles in relation to abductors is also a risk factor. So this shows us how important, how important it is maintaining this balance for the optimal balance in the whole area. Now let's talk about, so we can see that there are some specific factors biomechanical that are differentiating these athletes with higher risk of groin pain. Why that might be? If we again look at our lateral view from the side on the pelvis, and we look at these 2 muscles, abdominals and adductors, the theory is that if we look at it as a process, as what leads to these adductors being weaker. First of all, it might be that the weakness of abdominal muscle leads to unopposed action of adductors. We can see that they are exactly opposite. So if one gets weaker, then there is an unopposed action, which then leads to increased pressure in adductor compartment and then leads to pain and dysfunction. This is one of the potential mechanisms of that. Now, associations. So what we found in athletes who already have groin pain compared to these who did not. We found a series of factors that are decreased really in injured athletes. First of all, they are weaker in their adductors. They have a lower total external rotation, total meaning a sum of both legs. They are less flexible towards the abduction movement. They have a different abductor to adductor activation ratio, and also they have a decreased transversus abdominal muscle thickness. We also found some association that did not change. First of all, the internal rotation of the hips were not a factor that was differentiating the athletes with groin pain, which is quite interesting and might be helpful in diagnosing hip versus groin related problems. Also, we found that gluteal strength is not really changed. So we can see that we can establish some specific biomechanical risk factors and associations that differentiate the athletes with and without groin pain. So how do we go about this when we work in sports? How do we understand that biomechanics in sports? So majority of these studies that I've just talked about are easy clinical measures of strength and flexibility, which are great, which are very useful, quick, free, and you can just do them. However, groin pain is obviously mainly observed in high velocity, multi-directional, multi-structural movements. So how to understand the nature of those, how to tackle the biomechanical problem in these movements? So what I did in my research, I tried to do a little bit more functional movements. So I did a standing hip flexion and a single leg squat maneuver, which in my opinion is still an easy and clinically applicable moves. I've recruited 84 athletes and I divided them into two subgroups, professional and amateur subgroup. In professionals, I had professional footballers and rugby players. In amateur, I had frisbee players, footballers, and hockey players. Half of these guys are injured, half of them are controlled, very well matched. So what I did, I decided to have a look at the coronal plane muscle activation. I had a look at the adductor longus versus gluteus medius versus adductor longus activation ratio to see how they are doing. And I have also looked at the hip joint movement in 3 planes. So what I found is that in professional group, in both footballers and rugby players, the groin pain people had increased gluteus medius to adductor longus muscle activation, because the gluteus medius were higher activated. In amateurs, the trend was actually opposite. So the painful group, the ratio was decreased. They were leaning on their adductor muscle. Now the frisbee players did not show much difference, unfortunately. With the movement patterns during this single leg squat was following muscle activation. So we established that gluteus medius was more active in professionals, and they indeed showed more abduction. In the amateur group, they leaned on the adductors and seemed to turn off their gluteus medius muscle, and they did show increased adduction and internal rotation. So, which is the pattern of decreased gluteus medius activation. Frisbee players did not show much difference. Now, so we can see that there are biomechanical movement and muscle activation patterns. Now, how does this all relate to running? Because running is obviously also a movement that is high speed. Is it multidirectional or not? We're going to discuss this in a second. So obviously, groin pain is mainly visible in athletes of specific subgroups. However, in return to sport, we very often see that straight line running, apart from anything else, is quite difficult to come back to because of these higher loads. Why that might be? Well, first of all, during running, hip joint is a secondary power generator to the ankle. Secondly, as we said before, running is not like walking, that you have this relative less rest during double stance phase. You have a series of single leg stances really, which is done, increased speed and a longer levers, especially if you have a sprinter athlete. And also, I would like to suggest that running obviously is not, is not a single directional movement. Running is a multi-directional movement when we think about what's happening especially in the hip and pelvis. Now, this is looks like a very complex slide, but bear with me, because this is very interesting, and I really hope that you can use it in your practice as well. So this is sagittal plane. So we're talking about flexion extension movement. First, please look at the scale. These are degrees, because the scale will change depending on the plane. Second of all, up, we're going to mainly focus on the hip joint. So up is a hip flexion, down is a hip extension. Now this graph is a cycle of one leg moving. So from foot strike all the way to foot strike. And the hip is the continuous line. So this is how it moves. Now the idea is that when one leg is wherever in the cycle, the other leg would be 50% on the other side of the cycle, because obviously legs move continuously, yeah? So if we have a look at the right leg being red and the left leg being blue, if we can see at this person, right side is roughly just after the toe off. Therefore, your left side would be somewhere where the blue line is. And if we look at the hip, we can see that the right leg is probably in the maximum of hip extension, and the left leg is very close to the hip flexion. So these two legs are working quite opposite each other, and thinking about what's happening to the hip and pelvic joint, this is where we can see a challenge of the running. Now what we're going to do is we're going to have a look at the coronal plane, what's happening in there. This is again the same scenario. Toe off is here, and here is where the left leg is roughly. And we can see that again, in coronal plane, the abduction-adduction is working differently for both legs. But please do mind the scale. This is not such a massive difference here. It's just a few degrees, but it still might be quite difficult for the movement. In a horizontal plane, we have both legs being internally rotated at the same time, but again, the scale is quite small, so please bear in mind that. So these three graphs were only just to show you that the running movement may be as complex and as multidirectional as any other one, really. Right, so what are the clinical implications in running all these things? Now, I am not going to spend a lot of time here. I'm going to just rush through the early and middle stage of rehab, and then we're going to probably think about return to running a little bit more. So first of all, obviously we need to diagnose and identify the structure and weakness and imbalance, and the history. There are a few very useful links and resources online that you can use. And obviously, the clinical examination has been very well covered by a lot of other papers. I'm just not going to talk about that. Secondly, manage the pain. Thirdly, decrease and then gradually increase loading, which again, I have bigger experts in this room to talk about that, so I'm just going to skip. Optimize the range of movement. Introduce safe and controlled strengthening and more challenging program. Address all biomechanical issues, which you can see very often, seeing the pelvic drop and the knee valgus, or maybe a foot pronation, and return to run. So how do we do that? So the very common question that was also addressed very well by Anthony Hogan is, when can I run? So you have an athlete and he has groin pain. When can I run? What is the answer to that question? So first of all, it's very tempting to say, well, go for 2K and see how you do. You know, if you have pain, then, you know, clearly that was a little bit too early. But this is very difficult, first of all, ethically. Second of all, well, you can make the patient worse. And third of all, you can lose the athlete's trust as well, which you don't want to do as a clinician. So there was a battery of tests by Anthony Hogan that were used as a provocation test and as a decision making, and we're going to talk through them. There are 4 of them, and we're going to talk a little bit more about them now. So first of all, first stage is a walk and dynamic warm-up. So walk and dynamic needs to be pain-free. So if you want the athlete to return to run, he needs to walk pain-free, no pain during walking, no pain after walking, or no pain the morning after. And we're talking long distances, maybe 3, maybe 4K. We need to remember that these are athletes that we're dealing with as well. Then dynamic warm-up, short jogs and shuttles with knee to chest or heel to bottom. This needs to be pain-free. Second, adductor squeeze. Adductor squeeze test, which is very useful and very good indicator of what's happening with the injury right now. We are looking at the pain during the squeeze, but also we're looking at the strength with whatever you have, really, I think. It's mainly helpful for adductor and pubic-related groin pain, less so for other types of groin pain. However, what I like to see clinically is that when you put your squeeze test in a 90 degrees of hip flexion, so the athlete has legs up, it does incorporate some elements of abdominal muscle. Thirdly, unilateral resisted abduction. Now, the best thing is modified Thomas test. Why? Because when we thought about this running and the biomechanics, what's happening to the hip in the sagittal plane, we saw that at some point one hip is bent, one hip is extended, and this Thomas test is in a very nice clinical way to get athlete to this position. We are again looking at the pain and weakness. We simply put the athletes in this position, and we try to push him into abduction when the athlete resists with his adductor muscle. Again, needs to be pain-free and strong. The other one is the pubic symphysis stress. There is, as Christian said, there is no really consensus on the stress of that area. So, what to do? Well, maybe modified Thomas test again. It's such a nice clinical and running specific movement. So we can just bend this knee, which is anyway bent during running. As you can see, this left leg here is bent in one phase. And move it to extension movement, move it to adduction, abduction, move to internal, external rotation, and move to combination. And see if this hurts. Now, obviously, this is quite a provocative test, so I'm sure that if any of us tried to do that test right now on each other, majority of us would have pain at the end ranges. So I suggest we don't do that at the end range of movement. Now, from my perspective, as I said, I do believe that abdominal muscles are underestimated. So let's do not underestimate these abdominals, which provide essentially the anchor for the whole pelvis to provide the movements. Accessibility and pain or no pain during some progressive loading, and look at the gradual progression again. Is the athlete able to do crunch, resisted crunch, crunch with trunk rotation, crunch with legs up and trunk rotation? These are quite difficult exercises. If the athlete is able to do this, then probably we know that the abdominal issue is sorted. Now this is a very nice resource by Anthony Hogan here in the website. I suggest you really have a look at this article. It's very, very helpful. And this is just a little bit of a table with a system of lights. When can you allow your athlete to run, where you shouldn't do that, or when you should consider. Now I'm not going to go through them all, but this is a good indicator where you can think about your rehabilitation prognosis as well. You can see that if in some of these areas you are already in yellow or green light, and in some you're still stuck in red, then maybe it would be good to just try to refocus what you're doing with the athlete. From my perspective, I added abdominal function, but mind you that apart from this last row, all of these other criteria are actually reliable and valid. So this is where my addition comes. So I guess as a conclusion, and I think what just lay a nice ground for the next football talk, is that in groin pain, which is such a complex area, there is a lot of things that we need to understand and take into account. First, obviously, we need to know our anatomy, and we need to know the diagnosis and pathology of what's happening. Secondly, we need to understand the biomechanics. We need to understand the loading that is going through the area of all the muscles and tissues that are pulling and creating these torques. And the third of all, we need to understand the sport specificity. Have a look at what the sport does, even if this is something new for you. There's obviously a very, very big YouTube base of every sport. Just looking at what the hips are doing, what the pelvis is doing, and just thinking how to explore that clinically is very helpful. And thank you very much. Thank you very much for inviting me to your beautiful city. And I hope that maybe we can have a conversation after the talk.